Hello everyone and welcome to my channel. This is Asif Qureshi and you are watching Dr. Asif Lectures. Please subscribe the channel if you have not already done so and hit the bell icon so that you are updated with the latest content. Today, in this lecture, we are going to discuss about another very important laboratory report which is called UCE. U for urea, C for creatinine, and E for electrolytes, okay? Now, this particular report comes in different flavors. Depending upon what physicians require for the patients, some physicians prescribe only urea levels, some physicians prescribe only creatinine levels, and some physicians only prescribe electrolyte levels, or some of them may just simply prescribe UCE. It all depends upon what they need for their patient, what information they require for the management of the patient, okay? And therefore, you should understand from the outset of the lecture that this UCE is not a single parameter. It is an aggregate of different analytes and different parameters. This report contains urea, creatinine, electrolyte, all these levels. Also, there are many laboratories which report all these analytes on one single report. And then there are laboratories which report urea as a separate report, creatinine as a separate report, and electrolytes as a separate report. Okay, so it depends upon practice to practice. But anyways, important take-home message for you is that UCE is a combination of different analytes and different parameters. And we are going to discuss them all today. Now, because it is composed of a number of analytes, 7 of them, and therefore it is also known as UCE is also known as Chem 7 panel, chemistry 7 panel, because it contains 7 analytes, and it is also called the BMP panel. BMP stands for basic metabolic panel. Why we call it basic metabolic panel? Because in an inpatient, in an admitted patient, this panel gives you a lot of critical information regarding the patient. Okay, we will see what these analytes are. So now let's jump onto how does this report basically looks like. So here is a patient report. Obviously, the identity of the patient is hidden. And here you see the first part of the report talks about the electrolytes. How many electrolytes is it usually reporting? It's usually reporting these 4 electrolytes: sodium, potassium, chloride, and bicarbonate, okay? Here are the results and here are the normal reference ranges. So electrolyte is usually the first part of this Chem 7 panel, okay? Then, now, in many labs today, the analyzers which they are using, it basically calculates blood urea nitrogen. Now, urea levels can be calculated using blood urea nitrogen. I will tell you how is it calculated, but some reports mention BUN levels, blood urea nitrogen levels, while some reports mention urea levels. It again depends upon practice to practice and what basically physicians demand. Some physicians ask for urea levels. Some physicians are okay with the blood urea nitrogen levels. So I thought sharing all this information with you. So the Chem 7 or the UCE report or the BMP panel talks about electrolytes, it talks about blood urea nitrogen and urea levels, and then it talks about creatinine levels. So that's the basic, panel of a lot of markers which are reported in one single report, either in one single report or as separately. But all this information is there in UCE reports, okay? And each one of the analyte tells you very important information about the patient. Big deal to understand this, okay? Now, this is how we usually represent the Chem 7 parameters on a patient's, file or a portfolio, or when a doctor is making notes. So we make this fishbone analysis type of thing. So the first column on the left indicates the positives, and the positives are sodium ion and potassium ion, okay? The middle column represents the negatives, and the negatives are chloride ion and the bicarbonate ion. And then we have a renal panel, creatinine and blood urea nitrogen. Now, these 2 analytes talks about how is the renal function going within the patient, okay? And then we also measure glucose. Now, glucose is also, it is understandably not the typical component of UCE, urea, creatinine, electrolyte, but it is advisable to always get glucose levels whenever you prick the patient. So Chem 7 profile includes glucose along with all these electrolytes and blood urea nitrogen and creatinine levels, okay? So whenever a doctor prescribes Chem 7 portfolio, glucose has to be measured, and it has very important implications in interpretation of patient's condition, okay? Now, you should also focus on what are the units used for calculating all these analytes. Now, for all the ions, the positive ions and the negative ions, it is milliequivalents per liter, as you can see here. For creatinine, blood urea nitrogen, and glucose, it's milligrams per deciliter. It's written liter here, but it's usually the deciliter, okay? Milligrams per deciliter. All right. Now, also, important for you to understand this calculation. I told you the analyzers today in the chemistry laboratories usually calculate blood urea nitrogen. And then if you multiply this number by 2.14, it gives you the urea levels. So if a doctor has prescribed urea levels, you calculate BUN levels and multiply this 2.14. So this is the basic Chem 7 profile. Now guys, all the parameters in the basic Chem 7 profile are talking about something very important. Sodium ion tells you big deal information about something. So does potassium ion, so does chloride ion. So what I'm trying to convey in this lecture today is, number one, what is UCE? UCE is to calculate urea, creatinine, electrolyte levels in a patient's blood, okay? And this is also known as what? This is also known as Chem 7 panel. And the other name is basic metabolic panel. Apart from sodium, potassium, chloride, bicarbonate, creatinine, and BUN, what else is mandatory to calculate with Chem 7? Glucose levels, okay? So if you understand this, you should then jump on to the next concept, that what are the uses in terms of clinical management of the patient, what are the uses of each one of the analyte listed here? Let's talk about them very briefly. Each one of them will have designated lecture. I will prepare separate videos for sodium level disturbance, for example. What happens when sodium levels are increased? Hypernatremia. What happens when sodium levels are decreased? Hyponatremia. So that's altogether a different big discussion. Each one of the parameter demands a separate lecture. But today's purpose is to overview and give you the bird's eye view of all these UCE parameters, okay? Now let's talk about sodium first. Sodium levels basically tells you about the compartment volumes. Now, think about a patient coming to you in the emergency room and the patient has complained of profuse diarrhea. Now, if somebody is losing a lot of water, a lot of salt and water, what will happen to different compartments of the body? The patient will be hypovolemic, for example, low volume. The patient may have different and disturbed concentrations of sodium, which will have implications on the osmotic balance within different compartments. So when I say different compartments of the body, what do we basically mean by this? I'm sure you must be familiar with this diagram from your first year, second year physiology lectures. So that box in here tells you about different compartments. So there are basically two axes there. The x-axis is the volume and on the y-axis is the sodium concentration, okay? Now, here's the concept. Your body is basically divided into these two compartments. On the right side is the extracellular fluid or the extracellular compartment, anything which is outside the cell. And on the left side here is the intracellular fluid, ICF, or the intracellular compartment, okay? Now, intracellular is everything which is inside the cells. And notice that the ECF, extracellular fluid, and the intracellular fluid, they are separated by a membrane, and this membrane is called the plasma membrane, okay? And note, this is very important to understand, that this membrane is permeable to water, but it's not permeable to ions. So if sodium and potassium and all these ions have to cross between these two compartments, they have to go through channels, designated channels. Otherwise, they cannot simply diffuse through them, okay? Water can, ions cannot. And the extracellular fluid compartment is further divided into interstitial fluid, which is the bigger chunk, and the intravascular within the vessels compartment. And these two are then divided by capillary endothelium, okay? And which is freely permeable to ions as well as water. So Practically, the body is divided into extracellular fluid compartment and intracellular fluid compartment. So whenever you give a patient any intravenous solution, it goes first into which compartment? Extracellular. And then it may diffuse, depending upon what you have given to the patient, it may diffuse to the intracellular compartment as well, okay? Now, all this discussion is very interesting, and it is basically controlled by sodium levels. Now, if sodium levels are high, it draws water into that particular compartment. If sodium levels are low, it loses water and that compartment shrinks. So all those conditions where patient comes to you with diarrhea, where patient comes to you with a lot of hemorrhage, or the patient comes to you with syndrome of inappropriate antidiuretic hormone, all these type of things, diabetes insipidus, all has to do with sodium levels. So what I'm trying to emphasize is that on the UCE report, sodium level basically tells you about osmolarity and compartment volumes of the patient, okay? Normal sodium levels is usually 140 with a range, obviously. If it goes 2 down, say for example less than 135, or it goes 2 up, say for example more than 145, a physician should take note of it. And this is the basic diagram to understand. As I said, I will make separate videos for conditions associated with increased sodium levels and decreased sodium levels, okay? For now, just take the flavor. Now, potassium is an extremely regulated ion in your body with a very narrow range. And if the levels of potassium go up or go down, it disturbs the excitation potentials, okay? It's very important for nerve conduction, signal conduction things, and very important for cardiac rhythms, okay? So if potassium levels are disturbed, arrhythmias are very, very serious and can be fatal. Patients can die because of arrhythmias, okay? So this is something very serious, potassium levels. So sodium levels tell you about the volume within the compartments, and potassium level talks about the arrhythmias and excitation potentials, okay? Now, if you talk about the creatinine and blood urea nitrogen, do watch my video on kidney failures, because these two parameters are basically talking about kidney functioning, renal functioning, okay? Then if we talk about glucose, I have made a separate detailed video on the levels of glucose and how to diagnose diabetes mellitus, okay? So glucose tells you about the metabolic condition of your body. If a person has high glucose, what levels we have discussed in detail in my previous video on random blood sugar, fasting blood sugar, link in the description. Do watch the video. Now, if we talk about the negative ions, the chloride and the bicarb, very important to determine if the patient is experiencing, say for example, metabolic acidosis or alkalosis and that sort of thing, okay? So I'm telling you, each one of the analyte is giving you big deal of information. Sodium, volume status of the patient. Potassium, excitability and cardiac arrhythmias. Creatinine and blood urea nitrogen, renal function, glucose, diabetes, and now these negative markers. Now, these negative markers, I'll give you a flavor about this as well. It basically tells you about what is the anion gap. And based on the anion gap, if it's in metabolic acidosis or alkalosis, you treat the patient accordingly, okay? So, say for example, here we have a rectangle separated by a middle line, okay? And on the left is the positive ion column, on the right is the negative ion column. What is the major positive ion in your body which is regulating the volumes and the osmolarity? Sodium. And what is the normal level of sodium? 140, okay? So that's what is written here, 140 sodium normal levels. And what are the negative ions? Chloride and bicarbs. Now, chloride is around 104 milliequivalents per liter and bicarb is 24 milliequivalents per liter, okay? Now, so this is the major positive ion in your blood, and these are the major negative ions in your blood. But these are not the only negative ions in your blood. Remember that, okay? We do have a lot of other negatives, sulfates, phosphates, butyrates, palmitates, and all these 8 sort of thing are basically the negative charges. And that is the chunk here, okay? The empty square is the other negative charges, and those other negative charges is basically known as anion gap, okay? So we have the most abundant positive ion, which is sodium, and then on the right side we have 2 negatives, which is chloride and bicarb, which makes the majority. But then there is a minority, and that minority of the negative charges is known as anion gap. How is it calculated? Pretty simple. Anion gap is calculated using this formula. It's sodium minus chloride plus bicarb. So how much chloride do we have? 104. How much bicarb do we have? 24. That makes a total of 128. And if you subtract 128 from sodium, which is 140. So 140 minus 128 will give you the answer of 12. So the normal anion gap should be 12 milliequivalents per liter, which means that we have sodium as the major positive ion, and then we have chloride and bicarb as the major negative ions, and all the rest of the negative ions, including butyrate and palmitate and phosphate and sulfate, they add up together to a total of 12 milliequivalents per liter, which is what we call the anion gap. And you can only calculate the anion gap if you know the values of chloride, bicarbonate, and sodium. Okay, so each parameter in this Chem 7 profile is extremely important for patient management. Okay, let's extend this discussion a little bit deeper. Okay, now here at the top we have the Chem 7 profile. By now you should remember what is the Chem 7 profile. Is the other name for UCE. It includes sodium, potassium, chloride, bicarbonate, blood urea nitrogen, creatinine, and also glucose. Okay, now here is the normal looking anion gap. Sodium is 140, chloride is 104, bicarb is 24, and the anion gap is 12. So that is something normal. Also in the lower panel, this is the normal representation of how the anion gaps look like. Now let's talk about what if a patient develops a condition where the level of bicarbonate goes down. And whenever the level of bicarbonate goes down, this is what we call metabolic acidosis, and you should know this term. Okay, now if the bicarbonate goes down, say for example, now look this representation. Sodium is still 140, that is normal, but what is the level of bicarb now? It's gone down from 24 to 16, so it has gone down 8 points. Okay, so definitely the patient is losing bicarbonate. It can be because of diarrhea, it can be because of a lot of other things, but the patient is renal tubular acidosis, for example, or if the patient is given huge infusions of normal saline, all these things can lead to loss of bicarbonate. The point is, if you see the report and the bicarbonates are low, then you should look at chloride levels. Now chloride here is raised, 112. The normal value of chloride you can see is 104, so it has gone 8 points up. Now that's pretty easy to understand. You are losing 8 points of bicarbonate, but then the 8 points of chloride are increasing. What do you think will be the anion gap? Will it stay normal, or it will increase, or it will decrease? Let's remember in your head the calculation. It's sodium concentration minus sum of concentration of chloride and bicarb. What is the level of chloride now? 112. What is the level of bicarbonate now? 16. What will be the sum of these two numbers? 128. 140, which is sodium, minus 128 will still give you anion gap of 12. So the anion gap stays normal. The patient has metabolic acidosis because the bicarbonate levels are gone down. Since the bicarbonate levels are gone down, it is metabolic acidosis. But the anion gap is normal. This is what we call normal anion gap metabolic acidosis. In abbreviation, it's called NAGMA. It's a big name, but each word should make sense to you. Normal anion gap. Why we are calling it normal anion gap? Because the anion gap is normal, 12. Metabolic acidosis. Why we are calling it metabolic acidosis? Because it is losing bicarbonate. The levels of bicarbonates are going down. So normal anion gap metabolic acidosis can be because of a lot of different clinical scenarios, such as diarrhea, renal tubular acidosis type 2, carbonic anhydrase inhibitors, and lots of normal saline. We will discuss this when we talk about metabolic acidosis and alkalosis lectures in a separate video. But at the moment, I'm telling you how important the UCE report is. Imagine your patient in an ICU, an intensive care unit, and you are trying to interpret metabolic alkalosis, acidosis, what could be the cause, what is the treatment. It is important to understand these concepts, students, okay? Now, let's talk about the lower panel. On the left side is everything normal. Sodium levels 140, chloride levels 104, bicarb levels 24, and normal anion gap, okay? Now, let's see. Imagine this patient undergoes a situation where bicarbonate is lost. So this is the situation, okay? Again, same scenario, bicarbonate is lost. But here, chloride levels stays the same, 104. So the lost negative values from the bicarbonate are basically compensated by increase in the anion gap. Now, you see, here if you calculate the anion gap, if I ask you what is the anion gap in this scenario, let's do that. What is the level of sodium? 140. What is the level of bicarb? 16. What is the level of chloride? 104. So the total would be 130. Now, 120, sorry. So chloride 104 plus 16 will be 120. So if you subtract 120, which is the sum of chloride and bicarbonate, from 140, which is sodium level, the anion gap now will be 20. Now, 20 anion gap, what do you think? Is it normal? Is it decreased or increased? It is definitely increased. Now, this basically means that the other negative ions, which I talked about, phosphate, sulfate, butyrate, palmitate, salicylic acid, other negative ions have increased in number. Therefore, the anion gap has increased, okay? So this is very important. Now, because patient is losing bicarbonate, this is metabolic acidosis. And because the anion gap has increased, it is known as increased anion gap metabolic acidosis. Such a big name, but each word should make sense to you. Increase anion gap because the anion gap has increased. Metabolic acidosis because it's losing bicarbonate. So the name is increased anion gap metabolic acidosis, okay? And there could be several causes. If a patient takes a lot of methanol poisoning, for example, salicylic acid, ethanol, lactic acidosis, uremia. So in each one of these listed scenario, patient is actually having a lot of other negative ions. So when a lot of other negative ions are ingested or infused, the anion gap increases and the patient undergoes metabolic acidosis. So for normal anion gap metabolic acidosis, NAGMA, the causes are different and the management is different. For increased anion gap metabolic acidosis, the causes are different and management is different. I hope you appreciate how important is this Chem 7 profile. Increase and decrease sodium will disturb the patient compartment, volume, hypovolemia, hypervolemia, concentration issues, okay? Osmotic problems, sodium. Potassium, arrhythmias, excitation problems, very serious. Creatinine and blood urea nitrogen, kidney problems. They can be disturbed in kidney failure. Do wait for my lectures on acute renal injury and chronic kidney injury, okay? And then these negative ions, you calculate big deal of information about anion gap from these negative ions and glucose obviously for management of diabetes. So the Chem 7 profile is a key laboratory report to understand, and this is very critical for the patient. Sometimes doctors have to repeat this profile every few hours to see how the sodium is fluctuating, how the potassium is fluctuating. Remember in the first lecture I told you that every laboratory report is a snapshot. It gives you information of that particular time when the sample was taken. So a good doctor will always keep an eye on how is it progressing. Or what were the previous levels? How has it progressed now? So one snapshot, a sodium level of 140 can be good, can be bad, depending upon what was it yesterday and what can it be tomorrow. So if yesterday it was 150, today it is improving. But if tomorrow it is going to be 150, it's not good today. It's increasing tomorrow, okay? So the point is, Chem 7 profile is an extremely important laboratory report, and I hope you understand all the basic concepts. If you have hard time understanding these concepts, keep rewinding the video and watch the associated videos. For example, do watch the video on glucose level concentrations, okay? So with this, I end this lecture. These are my contact details. If you have any issues, do contact me and subscribe the channel. Thank you very much, and I'll see you again in another video. All the very best.